Right. I will go ahead and start doing housekeeping information as more people sign on, and we'll get you introduced and you're ready to go.
Okay, sounds great.
Good morning, everyone. We're glad to have you here today for our Trauma-Informed Care Wednesday webinar series, Interventions and Responses in Difficult Trauma Situations. There we go. We're glad you're here. This webinar is being recorded and will be available for people who could not be here today to watch it. Will be available for CEUs next week. As I said earlier, you don't have video or audio access, so please put information in the chat or the Q&A. The webinar was approved for CEUs for activity directors, administrators, nursing, and social work, and each of you will receive a certificate of attendance by email within the next week. Access to the webinar recording and the PowerPoint slides will be made available to you soon by email, will likely come with your certificate. And at the end, I'll be putting up an evaluation link. So if you can do that for us, it's great to get that feedback. So we're good to go to update anything that we need to update or show anything that we need to change. In that, I will also include information for the Ombudsman contacts and for the newsletter as well, if you don't happen to be getting the newsletter. Now, today we have Liz Wheeler. And if you were with us last month on February, you had Liz then as well. Liz has a whole alphabet of information after her name. She is currently a consultant at Leaderstat, and she's experienced in skilled nursing and assisted living, as well as long-term care pharmacy consulting. She's worked in various areas of care, including skilled nursing, subacute rehabilitation, assisted living, memory care, and more. Her main focuses are regulatory compliance, behavioral health, trauma-informed care, infection prevention and control, and quality assurance. Liz has worked and helped maintain CMS 5-star ratings and excellent survey results with many nursing home leaders to improve processes and outcomes. Liz, we are thrilled to have you here today, and we can't wait to hear what you have to offer us.
Wonderful. Thank you guys so much for joining. I really appreciated all the participation, our session last month. So I was excited to be invited again to do another session. So if you were on last time, just bear with me, we'll do a brief review. And if you were not on the last webinar, then I will do a brief snapshot of what we talked about last month, just in regards to trauma-informed care. As Susan mentioned, I've been in long-term care most of my career, and I have done quite a bit of work in the state of West Virginia and fallen in love with the state. So I'm currently in Athens, Ohio, working at a facility. So hopefully we don't have any interruptions, but I just want to put that disclaimer out there. Can everyone see my screen okay? Any issues, Susan?
Yes.
All right, perfect. So just to go over some housekeeping objectives, we'll be determining appropriate resident-centered interventions, specifically for some challenging situations that we have seen in long-term care recently. And I'll also be questioning you all of some situations that you may have experienced.
Liz,
yes.
It's not in slideshow presentation. We can actually see it in your PowerPoint window.
Mm-hmm.
I don't know if you just want the slide itself to show, but we can see your whole PowerPoint setup.
That's weird.
What if you click from beginning over at the left?
You know. What about now?
It's still showing the same thing.
It's
not a big deal. I know last time we had it up like that, but it's easy to see. So
yeah, I don't know why it's doing that.
Okay.
I apologize. I don't really want you all to focus on the PowerPoint anyway, so you'll get a copy of the slides afterwards. So if we didn't have technical difficulties, it wouldn't be a real Wednesday. So
absolutely,
bear with me and know that you'll get a copy of these slides at the end. And most of what we're talking about will be based on the discussion anyway. So we'll be applying some de-escalation techniques just in our changing environments, and then how to communicate with our teams on interventions. So we all have these great meetings sometimes, but the information doesn't trickle to the appropriate team members. So we'll talk a little bit about that. And then lastly, discussion in regards to how to implement some QAPI programs focused on trauma-informed care. If you already have a strong program, great. We'll talk a little bit about how to incorporate what you're doing into your QA programs. But if you're just starting or you're struggling with your program, that's okay. That's what QAPI is for. So we'll talk about how to capture some of that in your QA. For our first poll question, I would like to know who's attending, whether you're a nurse or a nurse aide, administrator, social worker. We just want to get a general idea of who we have on the call.
Answers are rolling in.
Great. And Susan, if you'll share those with me, I don't see them, so.
Where we were talking about, we've never used these before. Well, let me read through them real quick and then I'll end the poll and see if they pop up, because like I said, I've never done that before.
Okay.
13% administrators, 54% social workers, 14% RNs, 3% LPNs, no CNAs, 4% activity directors, and 13% other.
Awesome. That's great. I always like to know who we have. I love webinars, but it's
Can
nice
you see that now?
Yes.
Okay. Sorry. We apologize. We're learning a new part of the Zoom as we go along. So
Yeah. So just a brief overview of trauma-informed care. Trauma is identified as any incidents or situations that are disturbing to life. They can be threatening or non-threatening. We all deal with trauma differently, but it does have to cause an ongoing disturbance to functioning. And so just keep that definition in mind as you're building out your programs. And then I did want to just reference F699 trauma-informed care will be in your state operations manual just for additional reference. You will see trauma-informed care trickle into other F tags, but the home is F699. And the goal is to eliminate any triggers within our facilities while we're helping residents within our centers. Trauma can include physical or emotional abuse, neglect, history of sexual abuse or assault. We see a lot of PTSD specific to veterans. And so I know when trauma-informed care was first rolling out, we saw a lot of focus on veterans and PTSD, but just to remind everyone, trauma includes much more than PTSD. Natural disasters, I think we've all seen a ton of those recently. The poor state of California right now, Florida with a hurricane last year. And so anyone that has survived natural disasters needs to be taken into account. Holocaust survivors or families of genocide, history of car accidents, divorce, loss of jobs, death of loved ones or close friends, isolation, specifically to COVID. I think we all can say that we've gone through a traumatic experience. And so as we're evaluating our residents and doing assessments, to keep that in mind as well. And then, as I mentioned in the previous presentation and earlier today, other traumas are certainly experienced by some of our residents. And so Make sure that you keep in mind that we all identify trauma differently, we all experience trauma differently, and make sure you're asking open-ended questions and not just sticking to a short list of potential trauma situations. Brief overview of the principles of trauma-informed care: safety, trustworthiness, and transparency. We talked a lot about peer support and making sure that we're supporting each other and our staff to help care for residents and families. Making sure that we're harboring collaboration and mutuality. And then also making sure the staff feel empowerment, a voice and a choice, and the residents have a voice and a choice during their stay. Especially when identifying past trauma situations. The presentation that will be in June will focus solely on cultural, historical, and gender issues. So if you do have questions in regards to that, feel free to ask at the end today, but know that we are doing another session specific to those concerns. I'm going to run through these. Resident rights. Make sure that you're maintaining resident rights, which it's been on the forefront of everyone. We need to make sure that we're keeping the resident safe, but other residents and staff safe as well. And so I know it can be a challenging balance sometimes, but definitely keep that in mind when you're developing interventions. Trauma prevalence. I was shocked when I saw these numbers. The most recent data that I could find was from 2018. So that is pre-COVID. So it will be amazing to see what the data shows post-COVID. But they did show that 61% of men and 51% of women had experienced some type of trauma in their lifetime. And so I think we'll continue to see those numbers go up as awareness grows. We all experience trauma differently. I called on many of you last month to share some of your experiences, and so I really appreciate that. I took that to heart. I've also been talking to some of my clients and hearing some of the concerns that they've been seeing within their facilities, and we'll talk about a few of them today, specifically related to substance abuse disorder, natural disaster survivors, as well as dementia patients that have gone through traumatic experiences in the past and may not be able to communicate that information to the team. And so we'll go through some scenarios there. So what is trauma? We've talked about that. How do you determine a resident's trauma? That's the assessment piece. I will not go in depth about that again today. If you do need an assessment tool, I will send one out after the presentation. Oh, Susan, I'll send it to you, and you're welcome to share it with the participants if you're
your slides, at least on my screen, don't seem to be advancing.
Okay, I don't know why they're.
You still seem to be on slide 4 on what I can see.
Okay, I'm on slide 12. I don't know why it's doing that.
Well, nobody was complaining, so everybody was listening to you and not focusing on your slide presentation. But
okay, I'm sorry. I don't know how to fix it.
Click on your slide. Oh, yeah, they're moving now. Identifying trauma and trigger, slide 11.
So you can see it now. Okay.
Yes. Sorry, I didn't want to interrupt you, but you were kind of at a point there. So
I'm glad that you did. I had no idea that you couldn't see them. So, and I don't know why it's doing that. So again, I do apologize. Hopefully it doesn't take too much from the information that we're going over. But I do apologize for the tech difficulties.
It's a Wednesday with technology. It happens.
Yeah. And so we've talked about the different types of trauma and how to assess that upon admission and upon changes within the resident's condition and those types of things. And so if you do have questions about that, if you were not on last month's session, feel free to ask, but I will send out some information along with the slide deck after the presentation for your reference. Our main goal is to find out what we can do to help these residents. Once we've identified triggers, so talking with the families, talking with staff, if they've come from a previous facility, coordinating with that team and finding out what worked at the previous location so that you can implement it at your center, all of those things can help. Our main goal is to not re-traumatize. And so whether that's, assessing too frequently, asking too many questions, just keep that in mind. And then the goal in our environment within the facility is to not trigger any concerns. So maintenance projects going on, the loud sounds, change of shift, all of those things can contribute to triggers for some individuals. So just keep that at the heart of your concern. Poll question number 2. I'm curious how far along you all are in your programs. Are you just now starting? Do you feel like you have a well-functioning program? So Susan, if you could share that, I would appreciate it.
It is up now.
Okay, great.
And I did this one, I did yes, no, and not applicable, since some of our people are not in the facilities.
Yeah, that's fine. I know we're all at a different point in the process, and so as long as you're trying and trying to implement some of these things, I commend you for moving forward. It's not going away. And so certainly with some of the additional guidance coming out the end of October, I think we'll start seeing during survey activity that this is definitely at the forefront.
I'll give it just a few more seconds and then we'll end it.
Mm-hmm.
Can you see that, Liz?
No.
Wonder why. 31% said yes, they are having struggles.
Okay.
37% said no, and 32% said not applicable.
Okay. All right. So a mixture. So if you are struggling, don't give up, and you're definitely not alone. So hopefully you'll learn some strategies today. And if you have any questions at the end that I can help with, feel free to ask when we do the Q&A, or if you'd like to email separately, that's fine. All right. Once assessments are completed and triggers have been identified, those interventions need to be strongly developed. Obviously, they need to be resident-centered, and in order to do so, we need to make sure that we're talking with family members, direct care staff members to find out what's working for the resident, and making sure that those interventions are care planned and communicated to the team. Interventions are going to vary in effectiveness. So I strongly encourage not using a template format. So especially with the care planning process, I'm seeing some people build out care plan templates, which is fine for trauma-informed care. However, it's not one size fits all. So make sure that those interventions are being adjusted and edited to be specific for the resident. And some things like redirection, we can apply that to many individuals, but specifics, whether it's leaving a nightlight in a room or male versus female caregivers, those types of things need to be edited and not a cookie cutter approach. Frequently used interventions do not work for all individuals, and so thinking outside of the box is very important. And I'll be asking a few of you for some ideas that you've applied when we get to that point. But thinking outside the box is something that we all need to be doing, and not being afraid to contact family to discuss what was working at home, or as I mentioned earlier, if somebody was at another facility and they transferred to you, finding what they were doing. It should be a collaborative approach. And if something's not working, not being afraid to adjust. So reevaluating the effectiveness, just like we do for falls, would be helpful. When I teach how to implement these programs, I often reference fall management programs because they do have many similarities. So if you do have any type of at-risk meetings that you're having, I would suggest incorporating this into those discussions, and then reevaluating any interventions that are implemented to make sure that the effectiveness is well documented, or if it's not effective, that you're identifying some other options.
Hey Liz, your slides are still at the same place again.
Goodness. I'm sorry. I'm embarrassed by that, but I honestly do not know why it's doing that. I had a presentation earlier this morning and I didn't have an issue, so I'm not sure if it's Zoom or my connection or what, but I am sorry.
I'm just trying to point it out as we get to a break-in spot. So
yeah. Okay. Do you see the poll question number 3 slide?
Yes, ma'am.
Okay. So interventions. There are many interventions, and we'll discuss some of them. I have a list format, and then we'll talk about some scenarios. But one thing that CMS is very focused on right now is psychotropic medications, as you all know, specifically PRN psychotropic medications as it relates to agitation, any type of behavior. So I'm curious how many of you are utilizing PRN psychotropic medications in your facilities?
We have almost 50% that have responded now. We'll leave it up for just a little longer.
Okay.
Right now we have 75%, and we're looking at 45% saying yes, 36% saying no, and 20% saying not applicable.
Okay. All right.
I'll let it sit there for just a few minutes to let other people have a chance to answer.
Sure.
Answers have seemed to stop.
Okay, so PRN psychotropic medications are not all bad. So I just want to have that disclaimer. Medication management sometimes is a necessity. So keep that in mind, making sure that, you know, appropriate diagnoses are in place, that you're working with your pharmacies and your medical directors and providers for appropriate usage. Definitely reevaluating at the 14-day marks to ensure that they're still necessary. But I would like to challenge you all to think away from medications and put yourself in a resident's shoes. So if you're a new resident that moves in, maybe you had your hip replaced, you come into a facility, you're still groggy from anesthesia, the hospital thought you were agitated, so they were giving you Seroquel. Well, when the orders came over to the facility, they had Seroquel 50 milligrams at HS, and the nurse transcribed the order, and now they come into the room and give you your Seroquel again. I've never taken it at home before, and I see this time and time again where the order just stays on the chart. And so even if they are coming across as orders, make sure in your admissions processes you're looking at that for necessity. Also making sure that they have appropriate diagnosis for those medications. Was it home medication versus something that was initiated in the hospital? So just be mindful of that. Did my slide change, Susan?
No, ma'am.
Okay. All right. So when you get the slide deck, you'll see I put several slides on here. There's a list of interventions that are outside of the box. And so I wanted you all to have that as a reference. And so you'll receive that in the email. But outside of
Oh, it
there.
popped up almost full screen just for a minute and then went back down.
I'm not sure. But some resident-centered interventions, just to give you an idea, allowing residents to make their own choices, approaching with alternate caregivers, aromatherapy I've seen used, especially on dementia units or post-surgical patients. And so that's also an option. Making sure that we're offering, a hand rub or a back rub if it's appropriate. Rearranging clothing, making sure that communication boards are offered. All of these things are interventions that you can utilize in your program. And so there will be several slides with all of these interventions listed. So feel free to use that as a reference at your facilities. And then finger foods is another. I have a gentleman that I've been helping a facility with recently, and he is a veteran. He does have PTSD. He also has frontal lobe dementia, and we've been struggling with identifying what his triggers are. And so after speaking with a wife, we did determine that loud sounds are certainly a trigger for him. And we're in a nursing home. I mean, there's loud sounds all the time. And so just identifying and trying to keep those to a minimum has been helpful. But also, we've been offering him finger foods, and that's a really good redirection tool for him. So just keep that in the back of your minds as well. Guided imagery. I know we have a lot of social workers on this presentation, and so using resources like meditation, guided imagery, positive self-talk, things of that nature. Those are all great interventions for certain trauma patients. So you can utilize that. Repositioning. Keeping a separate bathing and hair washing for certain individuals as well. Giving tasks, realistic goals, having them help with a garden, or maybe you have bird feeders and they can help activities with those types of things. So again, you'll have this list. I just wanted to mention a few of the highlighted items. So let's switch gears and talk about some real life scenarios. So scenario number one, we got a 72-year-old resident with dementia that admitted the night before, and he's been trying to exit your building. The nurse has been asking the resident to sit down in his room between passing medications and answering call lights and phone calls. And the CNAs have been trying to redirect the resident to sit down in his room as well. When he admitted, the resident's wife shared with the social worker that the resident has been claustrophobic his entire life and experienced a traumatizing event in his 40s when he was trapped in a collapsed building for several hours. The social worker updated the resident's care plan and left for the day. In the meantime, maintenance was notified of an issue requiring a ceiling tile removal close to that resident's room. Tiles were missing and equipment was left visible but not accessible to the resident at the end of the day. After several attempts of encouraging the resident to sit down in his room, the nurse contacted the provider on call and obtained an order for Seroquel 50 milligrams every 12 hours as needed for agitation. The nurse obtained the medication from the emergency supply and administered to the resident. The resident eventually calmed down and was helped to bed by staff. The staff closed his door partly upon their departure. At 3 a.m., the CNA doing rounds finds the resident sitting on the floor at the room entrance. So, what went wrong with this? First of all, we all are very task-oriented, even when we try not to be, and our days get away from us, right? I think everybody can agree with that. Putting out fires is our main job, and then we have our task list that we have to complete. So to me, that communication breakdown between the families, the social worker, and the direct care staff is the first thing that occurred. So I encourage you to reach out to your team members, or if you have some other type of communication tools that you use to relay information about a resident's, fears, or, to keep the door open at all times, those types of things. The maintenance workers in this scenario obviously did not purposely leave those items to frighten the resident, but the visual aspects definitely with his dementia triggered a memory of the collapsed building, the loud sounds from the maintenance, being in a new space. And so some of this is avoidable, some of it's not. And then the psychotropic medication, again, there is strong evidence that psychotropic medications, specifically antipsychotic medications, do contribute to falls in geriatric patients. And so, again, medication is a necessity at times, but to be a primary intervention, I would strongly discourage against that. Attempting non-pharmacological interventions can be helpful, but if the staff don't have the tools to implement those things, then we can't fault them from falling on their own. So I'm curious if you wouldn't mind shooting over some answers. What else do you see wrong with this, or have you had similar experiences to this in your facilities? And Susan, I can't see them, so just let me know.
I was sort of saying nobody's putting anything in chat yet.
Oh,
Please feel free to respond to Liz's question in chat, and I will share that. Radio silence.
Oh, geez.
I'm like,
less interactive. I hope it's not because the PowerPoint's not working, guys. I do apologize for that. But I was just curious if you all had that type of situation. I see it very frequently. And maybe the names are different and the medications are different, and maybe a little bit different scenario, but the breakdown in communication is key here. And so I would really like somebody to share what's working in your facility. If you have a communication technique, I've seen some Cardexes used if you're using point-click care. I know that's a popular EMR program. I've seen rounding tools used just to communicate with staff. And so I just, one more time, if anyone wants to input what they're doing.
Yes, and unfortunately, there are always a chance for miscommunication. Boy, I can't talk today. I apologize. One said, could this have been mentioned to nursing station or staff on the wing as well as documented? They should have administered 10 to 15-minute checks.
Yeah, all of those are absolutely great. And also, because somebody's wandering, it's okay. And I think changing our mindset a little bit. As long as they're not harming themselves or another resident, it's okay if someone's walking around, as long as they're safe. It's okay if somebody is, getting up and down or not wanting to go into their room. And so just keep that in mind. I discuss with staff frequently about, are you doing an intervention because the resident is inconveniencing you, or are you helping the resident with their quality of life? And so just when you're talking with your teams, think through that with interventions, and making sure that you're utilizing things that are actually improving their quality of life, as well as helping staff redirect.
One of the responses is the PRN medication is like a hand over his mouth. It is a way to stop his communication of being uncomfortable in the form of wandering.
Exactly. Absolutely.
Sorry.
Absolutely.
Another said, I've seen it listed in care plans. And then also knowledge of the resident's background is elemental in discovering triggers and redirection. Communication between staff is essential to positive outcomes.
Absolutely. And based on that history from the resident's spouse in this situation, that closed spaces could be a trigger for him. And then the maintenance repairs, all of that could have easily been communicated. And then, talking with the spouse, digging deeper. Okay, he has a history of claustrophobia and he has a past trauma, but what do you do with that information? The next is to talk with a spouse and determine what's worked in the past. Okay, he doesn't like closed doors. He does not like loud sounds, those types of things, and making sure that we're mindful of projects in the facility. They are a necessity, but we can sometimes redirect residents to a different area. If maybe they leave the facility for an activity or with the family, and making sure that rooms are decluttered and doors are kept open, those types of things. So all of those are great interventions.
Liz.
Yeah.
An ombudsman shared, a lot of the facilities I visit have an overlap of staff, so they have time to download to the next shift any issues regarding special residents.
I like that. So kind of like a rounding or a report type situation, it sounds like. That's a great tool. So that's one situation. Another scenario. So we have a 47-year-old resident with a history of substance use disorder and intermittent periods of homelessness over the last several years. The facility has been without a social worker or discharge planner for several months. The admitting nurse completes a trauma screening and determines the resident has experienced homelessness in the past and is triggered by financial discussions, even though she has a place to discharge to, but will still need resources. During the resident care conference several days later, the MDS nurse informs the resident her payer source will only cover until the end of the week. No other discussion regarding discharges is covered. The resident sits quietly the remainder of the meeting. Later the same evening, the resident begins screaming at staff, refusing care, and becoming combative. So what went wrong with this? So I go all over the country to long-term care facilities and assisted living facilities, and what I've been seeing is missing team members. And we've always relied on social services to do so much when it comes to some of these discussions, or how to handle difficult residents, challenging situations, trauma in general. But for many of you, you may not have a social worker right now, or you may have new team members, or whatever the situation may be. But communication in this situation definitely broke down between that admitting nurse and the rest of the team. And so making sure that whoever's doing your trauma assessments knows what what the avenue is to communicate to the team. So most admitting nurses may not update a care plan, but maybe they can, fill out a communication tool for the rest of leadership and those types of things. And so we need to be aware of triggering fears of homelessness for people, and discussing payer coverage with residents is a necessity, but how we do it, offering reassurance in this situation would have been a good intervention. Making sure that the resident's discharge plan has been discussed at the same time that the payer source cut notice was discussed. And just that constant reassurance, and then avoiding discussing financial concerns without appropriate team members. And so, sometimes care plan meetings are few and far between, or there's only a couple of team members able to come at the time. And so making sure that all questions can be addressed and not trigger a resident that might have some financial concerns is definitely a necessity. Have any of you had an uptick in residents that have had financial concerns or discharge difficulties? Maybe
we had a couple of people who put in discharge planning should be initiated during admission, and billing financials should be discussing this with the resident. Ask the client what they want or need upon discharge. And one says the MDS person wasn't informed of the financial trauma that was involved here.
Absolutely. Yeah, absolutely. And so I did not just think these scenarios out of my head. These are things that I've seen in the field. And so the names have been changed and some things have been adjusted, but these things happen all the time. And it's not the intention of most individuals to trigger a resident. Most of our teams are doing the best that they can right now. We are all burnt out. We're all exhausted, and we're trying to stay afloat still. The pandemic really knocked us all for a loop. And so I certainly don't want you to misunderstand that I do not feel anyone is intentionally causing triggers. We just need to be more mindful of what we're doing in our facilities, the discussions that we're having with residents, and how they may be interpreted. So just challenge yourselves and your teams in that regard. Some other scenarios that we've seen, I did talk with some of the state ombudsmen prior to developing these webinars, and I did find out in West Virginia that you're seeing more autistic or developmentally delayed residents. And so I wanted to touch base on those individuals and how they experience the world differently. Overstimulation, specifically, we talked about the dementia resident, but specific for these individuals, bright lights, frequent movement, fast movement, loud sounds, all of that overstimulation can contribute to what we refer to as behaviors. And so making sure that we are aware of providing quiet spaces and calming environments for these individuals, not touching or hugging. We talked about the without permission, but we talked about that intervention list, and always with a permission, but sometimes just a hand on the shoulder can be very beneficial. But if you are dealing with a resident that has a history of autism, or they are developmentally delayed, or have a history of sexual or physical abuse, we always need to ask if it's okay before we do an intervention such as that. Avoiding sudden changes is another. Making sure that we're explaining tasks, making sure that we're making sure that we're communicating clearly and frequently with these individuals and families as well. So are any of you that are on the call, do you have residents that fit this situation?
I'm watching the chat. Absolutely. Okay. Yes.
Yeah. Me too, especially I'm in Southern Ohio, as I mentioned, and I'm definitely seeing increase as we see this change in resident population. We need to make sure that we're giving our direct caregivers specifically the tools that they need to care for these individuals. And so whether that's bringing in someone to do additional in-servicing or role play exercises, it can be very, very helpful. Natural disaster survivors too. Last month we briefly talked about hurricane survivors or any type of natural disaster, but one thing to keep in mind is giving advance notice of fire alarms or drills for natural disaster survivors that have identified that that they may have trigger concerns. They might be more panicky during actual events or a drill. And so making sure we're providing extra support during those situations can be very helpful. And knowing who those individuals are. And I originally, when I put this presentation together, I wasn't going to talk about this again, but just this past week, I was in a center and I was there later in the evening, and one of the residents pulled the fire alarm. He has dementia and he was wandering and just tinkering, and he pulled the fire alarm. And I noticed one woman in the common area that got under a chair. And it dawned on me that I didn't know her, and I didn't know why she was doing that, but I realized that the sound was causing her to do that. So upon further investigation, once the fire alarm was shut off and those types of things, she shared with me that she had been through a tornado, and even though it was a fire alarm, she just automatically assumed we were having bad weather that day, and she just assumed that's what she needed to do. And so it was funny after the fact, but it did dawn on me that we should touch base on this, because we are going to start seeing individuals that have been through situations, whether they were a 9/11 survivor or a collapsed building survivor. The collapsed building down in Florida a couple years ago comes to mind. And so just keep that in mind when you're doing those drills. Do you have any other situations that you have had challenges with that someone would like to ask about? A challenging trauma or a challenging resident that you're struggling with interventions? Anyone want to share?
Nobody wants to share these.
Okay, that's all right. If you think of any later, feel free to email, and I'm happy to assist with any of those. Let's briefly talk about care planning. We did talk about identifying the problem and the goals on the last session, so I want to focus on interventions. And again, re-traumatization is what we want to avoid. So all interventions, the whole point is to reduce the risk of re-traumatizing a resident. And so make sure that those interventions are clearly outlined. Now, if you are care planning, as your sole means of communication, make sure that all of the staff have accessibility. I know in some facilities, nurses access care planning and they can see interventions. I've seen some people put it on an order list, the Cardex, a communication sheet. And so all of those things are fine as long as they are being matched up with what the care plan actually says. Interventions need to be shared with the entire team. And so nursing, obviously, therapy, social services, but also activities, environmental services needs to be aware, dietary, maintenance, anyone in administration, anyone that could potentially interact with the residents needs to be aware of those interventions. And so the triggers can be avoided. And so just don't forget any of your departments when you're working on your communications plans. Huddles are a great way to do so. Team meetings. Also, I've seen where weekly, maybe in a morning meeting, clinical leader will discuss new residents, new triggers, and then those department heads go back and discuss with their teams. So that's an idea that I've seen implemented recently that's been functional, but there's not a right or wrong way to do so. For QAPI, as promised, you want to review your intervention development process. So early on, we asked, if you're struggling with your program or if you feel that you have a strong program. And so even if you feel you have a strong program, I encourage you to review your intervention development process and your communication processes. And if you do identify any gaps, take credit for those. Gaps are okay. What you do with those gaps is what's important. And so any update to processes needs to be documented. Facility assessments also need to be updated. So if you admit a resident that has PTSD, you've never had a resident with PTSD, you need to make sure that your demographics are updated in your facility assessment. As well as any competencies that may be associated with your trauma-informed care program. And so just keep that in mind. I do want to see if anyone has questions. So I saved 10 minutes at the end of this. So feel free to use the chat. Any Q&A is welcomed.
I think time change has us all messed up. Everybody was really interactive before. Now
I'm sad. I know it's a Wednesday and I know we're all tired. And I know I've said it multiple times already, but I am sorry that the PowerPoint is not working properly. I have no idea why that is, but you will all get a copy of it. I'm sharing the resources now. If you do have residents with autism or other developmental delay, I did find a really great resource. It's out of Oregon, but traumainformedoregon.org. It'll be on your resource list. I was really impressed by their website and their free resources and training materials. So feel free to check that out. Susan, I'm not sure. I looked for West Virginia to see if there was one available, but certainly if you have a link that you'd like to share for that, feel free.
everybody's talking about the time change. It's after lunch. Everyone's sleepy.
That's okay. I don't mind. I really do appreciate everyone's time. And I hope that you've enjoyed the discussion, even though you couldn't see. But I do appreciate your guys' time. And if you do have questions, feel free to email. I'm happy to respond via email.
I did put a link in the chat that I hope sends you to the actual survey this time and not a blank screen. If it does, you'll get that as soon as I get off here. I'll send emails out. So,
okay.
Does anybody have any other questions, any comments? Just me and you here, Liz. Everybody.
I know. That's all right. I'm glad that they liked it. But I feel like we need some sort of brainstorm and role play seminar where we all bring our case exam. Oh, I love that idea.
That's what I was just reading as well. I agree with that totally. Making note of that, Jennifer, and we'll see what we can work out.
Yes, I would love that. That sounds really great.
And yes, everyone will receive the recording of this along with the PowerPoint slides and your certificate of attendance. And again, CEUs are rewarded for this, as well as for the recorded webinar. If you have people who didn't get to watch it, that will be available just to watch for the information or for CEs as well. But again, you will be getting the slide. And if you have any questions, feel free to email me and I'll get those to Liz and then get those questions answers back out to everyone who attended.
All right, wonderful. Thank you guys.
Thank you. Everyone have a wonderful, wonderful day. You will be getting a link about I don't even know what month it is, the April webinar that will be focusing more on developing social histories and those traumas that people have to work hand in hand with the care planning so we can best serve our residents. So again, you'll be getting a link with the information from this, as well as a email with a link to sign up to attend next month's webinar as well. Thank you, Liz. I appreciate you, and we'll see you again in June. July?
Yes, in June. And,
June, okay.
And we won't have technical difficulties next time.
We'll get it straightened out. Next time you can send it to me in advance, and that way if it happens, maybe I can try to share it. So
I think that sounds like a great idea. All right.
All right.
Bye.
Thank you. I don't know why the link to the evaluation is not working again. I will send it out in the email later today. I apologize. Apparently it's Wednesday, technology mishap day, and everything that can go wrong, technologically speaking, is going wrong. So everybody have a great day, and I will get the evaluation to you. Thank you for your attendance and your interaction. And please let us know if there are other topics and thoughts that you think may be helpful for us to get out to you as well. Thank you so much.